Thank you very much, Karen, and also Timmy and Kate for setting the stage. Hi, my name is Dykki Settle. I am the team lead for Health Workforce Informatics team, the iHRIS team at CapacityPlus, and I'm going to talk just a little bit about what iHRIS is, where it is, give you all the up-to-date numbers, and talk about what we'll be discussing throughout the afternoon. Okay, so we usually like to start with why is good health worker data important? And everybody has a piece of the puzzle. Understanding that data is necessary for one part of the health workforce support or another, but it's really used across the entire life cycle of the health worker, from workforce planning to education and training, both pre-service and in-service, regulation, the registration and licensure of qualified health professionals, deployment to get health workers where they need to be, management, promotions, transfers, movements within the active health workforce, and of course retention interventions, keeping those health workers engaged in providing high quality services. The whole goal, of course, is to get the right health worker with the right skills to the right place at the right time to provide quality services. Now, of course, when we began in the Capacity project and we started to look at the current state of health workforce information systems, this is what we found. And we found it everywhere. Okay, good. If you need to find a record, you have a reasonable chance of finding a single file on a health worker. But if you need to make wholesale changes like retire everybody over age 65, or perhaps do some analysis or some aggregation of the data, it becomes incredibly challenging. And that's where ICT and information technologies come into play. Getting from moldering, sometimes not even available paper forms, to an electronic system where you can capture this data and on the fly, on demand, analyze it and use that data effectively to make policy, planning, education, training, management, deployment, all the decisions that need to be made to support the health workforce. Okay. At the heart of iHRIS, the heart and soul of iHRIS is open source and open source approaches. And we're going to keep coming back to open source as a recurring theme because we firmly believe this is the way to do international development in ICT. Building local capacity, building local ownership, local innovation, support, sustainability. This is the way to do it. And I hope by the time you leave, you're just as excited about open source as we are and the opportunities that it represents. Okay, part of the reason open source is important is building the community of stakeholders. And we're talking about the health workforce, all those components I mentioned earlier. That's a lot of stakeholders. There's a lot of roles and goals, whether it's the dean of students at a health training institution, whether it's the HR manager or supervisors at a Ministry of Health, registrars at professional councils, any number of stakeholders have a role to play in supporting the health worker or the health workforce at large. And bringing those groups together into stakeholder leadership is the only way to design and architect a comprehensive health workforce information system. Also, in addition to stakeholders affecting the health workforce information system is not alone. It is a component of larger health information systems and different frameworks that health workers, using the broader definition that Karen explained, going beyond clinicians, but also to all of the people who affect and improve healthcare. The WHO definition, anyone who, where the primary part of their job is contributing to health, is a health worker. But these health workers, and in this case, a clinician, have different interactions. And this diagram shows technologies, example technologies, that are used in the health workers' interaction with these different interfaces. Whether it's the health system on the bottom, interacting with knowledge, accessing knowledge management and services and learning and information on the right-hand side, their care, giving to the health consumer on the top, and their colleagues, peer-to-peer support, supportive supervision, all of the components that go into providing that quality services. Now, iHRIS, when you focus on the health system quadrant, is the fulcrum of the health worker. It's the system that understands the health worker, that supports the health worker, that makes all of those support functions across the life cycle possible. And by having a strong iHRIS, you not only understand the health worker and the health workforce more broadly, you have strategies and tools for effective use of this data and information, and also begin to explore new directions of what's possible when you have a deeper understanding of the health worker. Now, drilling down on iHRIS, you can sometimes say, oh, we've got an iHRIS, that's great. But one iHRIS does not serve all of those stakeholders and all of those roles and goals within the ecosystem. Of course, there's the Ministry of Health in many countries, if we look at the public sector first, and not just the Ministry of Health, but Ministry of Education, Ministry of Public Service. There are many national level stakeholders who have a role to play in supporting an effective health workforce. And of course, you have the local facilities and service providers themselves at the local level. There is sometimes, in more decentralized countries, a level of local government, regional and district authorities that help support those local health workers in collaboration and coordination with the Ministry of Health. And connecting those, in every country we've ever visited, has been work towards an HMIS, some type of indicator reporting system to track health services and support. And when it comes to health workforce, there's usually data, but it's very limited. You usually have cadres down the side, you have districts across the top, and you got a bunch of boxes with numbers in them. So you know how many nurses are in your central district, for example. Again, very difficult to manage with that level of information. You may start to have a sense of that density, but how do you really reallocate and begin to address that with only that information? Now, one place you might turn is perhaps the payroll system, particularly if we're talking about the public sector. But a payroll system isn't designed to support health. It's designed to get people paid, all the people in the public sector. Rarely do those systems have health-specific information. Cadre information is often missing. Pay station data is usually included, but not duty stations. So you might know someone's paid in a district, but you may not know what facility they're at. And so there's a big gap in that data to really provide effective health services. And of course, the biggest gap, the public payroll system does not have the private sector, the FBOs, the NGOs, the for-profit organizations, and they are growing and becoming ever more important. And the organizations themselves and the associations they form will support their own HRIS systems. They also want to pay their workers and have a certain amount of information. So this is the picture of service delivery, active health workforce. But you don't have a complete picture. And the conversation right now, looking a little bit into the future, is around health workforce registries. How do you get a minimum data set of information from the public and the private sector to get a complete picture of the health workforce? A great deal of work is focusing in that area right now. Countries are beginning to explore how do we support and build national health worker registries in conjunction with other health information registries, facility registries, for example. Okay, at this point we have a pretty good picture of the active health workforce from public and private sector. Two other very important sources of data. Training institutions give you a sense of the pipeline, who's coming over the next 4 to 5 years, what is going to be your future health workforce, not just your existing one. Also, how are the capacities and skills being built through continuing professional development and in-service training. And very important, the professional councils for the doctors, the nurses, the midwives, the pharmacists, the dentists, the lab technicians, all of the professional health workers who are regulated to ensure high-quality services are carefully managed by those professional councils and the registration and licensure of those health workers. So we finally, at this stage, begin to have a more complete picture of the sources and uses of health workforce data. And with this particular diagram laid out in this way, we can have the public sector on the left, the private sector on the right, the national level in the top half, the local level in the bottom half. And by pulling it all together, we get quadrants where we can attend to, are we getting all of the data we can from all the possible sources throughout a country's health system, from the national public sector in the upper left to the local private sector in the lower right. Okay, and supporting all of these roles, goals, organizations to serve the health workforce well. Again, not one solution, but applications that can be built on the same architecture can support these different needs of the health workforce. Towards that end, iHRIS Manage, we have developed to support managers, deployment, support for the active health workforce. iHRIS Qualify for those health professional councils and the registration and licensure. iHRIS Plan for workforce planning and modeling to begin to look into the future of the larger trends of the health workforce. iHRIS Retain, planning and costing retention interventions, building on the WHO rural retention guidelines. And iHRIS Train, tracking pre-service and in-service training to make sure we're getting the most efficient bang for the buck in training, planning, and delivery. All of that software is supported, yes, by the global project, but even more so by iHRIS's global community. Today, over 200 active participants around the world, developers, implementers, users of the software, come together to identify how can it be improved, how can it be built upon, how can it really meet their needs. Over 400 issues. And by issues, it can be a simple bug that made it through quality control, or it can be, hey, how do I do this? Or, hey, I want to design a whole new module. Can be brought to the community. Over the last 1.5 years, over 400 of these types of issues have been brought forward. Sometimes they're raised in India, and then addressed in Kenya and Tanzania, and then Nigeria weighs in, and Senegal and Ghana, and the problem is solved before the US even wakes up in the morning. This is the power of open source community and support for technologies. USAID is absolutely the cornerstone investment of the software, but it's been wonderful to watch as different donors have gotten engaged as countries have looked for support in different implementations. As Karen mentioned, it has gone beyond the sphere of USAID in some countries and being supported by other donors in smaller implementations. There are also 8 different implementing organizations. Many of these organizations are represented here today. If you didn't know that your organization is supporting an iHRIS implementation, come see us and we'll tell you all about it. Because goodness knows we find out new things all the time. And as was mentioned, this keeps getting updated. Our total number of workforce records, not quite all health worker records, is at 1.25 million in iHRIS across 19 countries. Now, what does that community do? And I think this is one of the greatest examples of community and what the community has done. And the way the open source software is implemented, it supports open translation of the software. Most of these translations have not been supported by donors, but by the community itself who wanted to take, adapt, and apply iHRIS and make it useful. As many as 25, iHRIS has been translated into as many as 25 languages, at least some component of it. I wanted to list for you the very top 12 languages that iHRIS has been translated into by the community. So here are the current 19 countries. We consider a country actively using iHRIS if there are active records being used to support the health workforce. We always have a number of countries in the pipeline. Some come, some go. We don't consider it stable, solid, and countable until we know those records are actively being used. The red countries in this diagram are being supported directly by CapacityPlus and CapacityPlus field support implementations. The blue countries are largely USAID bilaterals that are contributing to and supporting iHRIS implementations. The green countries are other donors or independent adoption in a few cases of iHRIS. Independent download, customize, adopt, implement. Very exciting stuff. Okay, so here is some detail. Far more than anyone has any time to read, but it begins to give you a sense, again, of the variety of projects, implementers, also donors and activities, and the levels, the number of records each of these countries support. Happy to share any of these details with you during the afternoon. The total, precisely today, is 1,255,956. As I said, not all health workers. That's largely due to Tanzania's implementation of iHRIS, not just for the health workforce, but for all public sector workers at the local level. So their number at 347,000, 298,000 of those are not health workers per se, but agriculture, other kinds of government workers, recreation and leisure, anything you might imagine in terms of the public sector support. And we have one of our colleagues from Tanzania here today who really led some of those implementations and can tell you more about how iHRIS can go beyond the health workforce. So what do we get for a health workforce number? About 950,000. I was really hoping we'd crack 1 million. I'd be able to announce our 1,000th health worker today, but or it's definitely right around the corner. Okay, now that we're on the subject of numbers, let me give you some real concrete numbers about what iHRIS has been used in countries to achieve. It's been used to save money. It was mentioned 149 million earlier. That was just a quarter ago with the new numbers. If that number of health workers were to be supported by the leading proprietary software license fees, it would have cost $177 million to deploy. And that's just the software license, not customizing, not adapting, not paying for all the consulting services required to put in a system of this scale. and $39 million in annual license fees. So this is money straight out countries implementing iHRIS did not have to pay to a large software vendor. Another way countries are saving money is by identifying the redundancy and challenges in the health workforce. Sure, many of you are familiar with the ghost worker challenge in payrolls around the world, where people are getting paid that are no longer actively providing any services or work. A tool like ours lets you analyze consistently and clean the payroll of those ghost workers. Also, some countries are able to identify people who have multiple positions, because when you've got a system that isn't very functional, you can do that. You can have as many as 3 jobs and get paid for them all, even if you aren't doing them. Or perhaps you've left the country to go study and you're still getting paid for your job when perhaps there was another mechanism in place. Cleaning the payroll brings a great deal of money. Specific examples are a little challenging, of course. This isn't something countries like to be made public, but we hear all the time about the money that countries are saving. Advocacy, and we've heard already, and we'll hear more about Uganda's use of iHRIS data in 2013 to advocate for a $20 million recruitment fund, filling more than 7,000 identified vacancies. When you're talking about a workforce about 60,000 in total, that's significant, more than 10% increase. Workforce planning. The Mali Ministry of Health uses iHRIS twice a year. They review their staffing and their ratios nationwide, particularly in the northern districts, regions of Mali, where there are many challenges ensuring that health workers are providing the support and services that they need. Uganda uses iHRIS Train to plan for nearly 30,000 health students currently in training. That's your future workforce right there. You know what cadres are coming, you know what you need to tune, you can provide feedback into the educational system and make sure that they're training the health workers that you need. Regulation. Uganda Medical and Dental Council used iHRIS Qualify to increase its relicensure compliance from less than 100 to more than 2,300 doctors every year. That increase in compliance not only improves the quality provided by the professional council, but also increases the revenue that comes into that professional council to help ensure ongoing quality of the health workforce. And deployment, looking at deployment challenges and addressing them. One state in India used iHRIS to identify and address OBGYN gaps in 60% of their facilities. And then they planned interventions to address it. They started redeploying, they started training more, they worked on attraction interventions, and they started providing EMOC training to its health workers already there in order to address this gap. Malawi Ministry of Health, and it's not just health services, it's also the efficiencies and those other aspects of the health worker. When the Malawi Ministry of Health compared mechanics to drivers in their motor pool, they found 700 drivers and 4 mechanics. And they were shipping and sending mechanics all over the country to support those 700 drivers in all of the districts and all of the materials and the tools. They said, wait, this isn't possible. That even scales. Uganda, looking across that 60,000, going on 67,000 health workers, only has 10 ICT professionals supporting all of the eHealth, mHealth, and other health systems interventions. We need those health information technologists and workers to support not only iHRIS, but all of the many information systems and technologies that are supporting health workers to do their job. Okay. Today, I would like to introduce, in the Capacity Project, we released the iHRIS Strengthening Implementation Toolkit, some of the tools that we had pulled together in implementing iHRIS around the world. This past year, we've worked with the community to develop a new toolkit. This toolkit's more focused on iHRIS implementation, and it invited contributions from the community. 12 country teams contributed tools that they had developed, more than 100 tools that support the implementation of iHRIS. Everything from data collection forms to planning forms to tools to project manage software implementation, everything an implementing organization might need or country that wishes to implement and work with iHRIS software. All of these tools have been pulled together, are being curated, and will be made available on the web in a way that countries can continue to contribute their tools, download and adapt tools that others have developed, and continue to build and grow on the tools that the community has built. And I think that largely rounds it out. For me, we've got a little bit of a video we'd like to share. I bet you've all been sitting and listening to us for a while. It's time for some coffee. During the break, we want to show you one example of how a country, Uganda, is using iHRIS as part of its comprehensive health workforce strengthening plan. In this short video, you'll meet Agnes, Alex, and Abiba, 3 health workers in Uganda who love giving care to their clients, but face many challenges. Simply aren't enough health workers to meet the community's demand for health care. You'll also find out about just 3 of Uganda's many health workforce interventions, including implementing iHRIS at the Ministry of Health in over 80 districts, 5 national institutions, and all 4 professional health councils. Uganda's health leaders are using iHRIS data to make informed decisions about the health workforce and to advocate for more health workers. And you'll hear again about the recruitment fund and the 7,000 additional. So please, grab a coffee, a snack. It looks like we're running pretty well on schedule. We'll try to get started again in about 15 minutes. Let's call it 2:05. And I will talk to you a little bit about the tables that we'll be having so you can dig in more deeply on some of the iHRIS topics and themes. Thank you very much.